Right now, roughly 1 in 5 people carries a genetically supercharged cholesterol particle that drives early heart attacks. It's called lipoprotein A, or LPA. Standard cholesterol panels completely ignore it, meaning millions of people are unaware of their specific risk level. Because there is currently no FDA-approved drug designed to directly lower this number, many doctors avoid testing for it. The typical clinical logic suggests that finding a problem without a direct pharmaceutical solution isn't worth the effort. However, a specific one-time blood test for LPA, measured in nanomoles per liter, costs roughly $40 out of pocket. That $40 buys a strategic roadmap. Knowing your baseline allows you to prioritize the health inputs you actually can influence, while the LPA itself remains a fixed variable. This comparison shows the structural difference. A standard LDL particle on the left is a simple sphere. On the right, the LPA particle is wrapped in an extra, jagged protein called ApoA. That jagged protein acts like a hook. It makes the particle stickier, increasing the likelihood that it will snag on artery walls, build plaque, and promote blood clots. While LDL levels fluctuate based on diet and exercise, your LPA level is dictated by the genes you inherited from your parents. This level is locked in by your early teenage years and remains stable for the rest of your life. Curiously, LPA only appears naturally in primates and hedgehogs. This rarity made it difficult to study in standard lab mice, slowing medical understanding for decades. Since you cannot diet or exercise your way out of a genetic baseline, the strategy shifts to managing the surrounding cardiovascular system. This chart evaluates the 4 main strategies for managing high LPA, weighing the effort and cost against the actual reduction in heart attack risk. The first intervention is strict lifestyle management: whole foods, low saturated fat, and daily exercise. This approach drops ApoB, blood pressure, and inflammation, lowering overall cardiovascular risk by up to 70%. This requires high daily discipline, but it should be noted that lifestyle changes will not move the actual LPLA lab number. Next are statins, the standard medical play. Statins work by lowering standard LDL cholesterol. Clearing these other bad particles out of the blood leaves the dangerous LPLA with fewer partners to build plaque. Counterintuitively, statins can increase LPLA levels by about 10%. However, the medical trade-off is absolutely worth it. A slight increase in the LPLA metric is a secondary concern compared to the significant, proven reduction in actual heart attacks provided by statins. Some turn to over-the-counter supplements like niacin or berberine to force the LPLA number down. Niacin does lower the LPA lab number by 20 to 30%. But clinical trials show that lowering the LPA number with niacin does not result in fewer heart attacks or strokes. Furthermore, niacin carries risks like severe skin flushing, elevated blood sugar, and liver stress. Lowering a number on a lab report is meaningless if the intervention fails to stop the actual progression of artery disease. For those seeking maximum risk reduction, there are PCSK9 inhibitors. These injectable drugs lower ApoB to pediatric levels and are the only current option that also reduces LPA by roughly 30%. Because insurance rarely covers these specifically for LPA, patients often face out-of-pocket costs of thousands of dollars a year. PCSK9 inhibitors provide high levels of protection, but the high cost limits them to those willing to pay a premium for optimization. This decision tree simplifies the next steps. Start by spending $40 for a one-time test. A result under 50 nanomoles per liter means your genetic risk is low. You never need to check this again. A result over 125 puts you in the top 20% of risk. On a standard budget, the priority is to work with a doctor to drive your LDL under 70 using diet and statins. On an optimizer budget, you can consider using PCSK9 inhibitors out of pocket. Regardless of the budget, the primary goal for high-risk patients is the aggressive management of every other cardiovascular metric. Targeted RNA therapies, such as pelacarsen, are now in late-stage Phase 3 clinical trials. These drugs target the liver's genetic instructions, with early data showing LPA reductions of 80 to 90%. Market approval is still 2 to 4 years away, and these drugs will likely be reserved for the most severe cases initially. Identifying your LPA status early buys your heart time. It allows you to use accessible tools to maintain health until targeted genetic therapies become a reality.